Dr. Cleary has to go to the hospital soon, but before he leaves, just want to show him a couple of cases, and because I think it'll be kind of highly relevant. So I want to ask Marisha, do you want to come up to show your, and then we can open up for the panelists to discuss these cases. We have several cases that illustrate the treatment challenges with polycystic liver disease. And
may also has one PLD case.
Which one? Are you doing the first one? Okay. Can you do it quickly? Yeah. Okay. Maybe you can go to the, yeah.
Good afternoon, everyone. Thank you for an amazing presentation, good information, good day overall, and thank you for the opportunity to present today. So we'll be presenting, me and my co-fellows, a few cases today. Hopefully they will be intriguing, interesting, and hopefully we'll have a good discussion. So case one, I have a 45-year-old woman who's seen in clinic for the first time. She's complaining of abdominal distension. She's having early satiety. She's having daily abdominal pain, difficulty exercising and laying down. There is a past medical history, or there is a family history of PKD2, mainly in her father. There is no family history of any intracranial aneurysm, and her only medication is probiotic. She's not known to have any allergies, and social history, she's a non-drinker, non-smoker. You can see here from her examination, she appears to be a petite woman, weight 49.5 kg, height 158 centimeters, and her abdomen when she first presented to the clinic was quite distended, enlarged liver to the level umbilicus with some tenderness. Investigations, as you can see, they were mostly normal CBC, electrolyte, blood glucose, liver enzymes, and lipid. Her creatinine was at 74 with slightly decreased eGFR for her age. So this is a video. Hopefully we can play it. So this is her MRI when she first presented to us in 2018. And we can see on the left-hand side that this is her report. So her kidneys, total height-adjusted total kidney volume was 1,191 ml. She was classified as myoclinic imaging classification 1D for her polycystic kidney disease. As for her liver, it was 4,632 ml. So this is a... Oh, that's a great question for radiologist. Anyone would know?
Mil?
Yes, for that's roughly, she's having 4.5 kg weight due to her liver. And as you can remember, she only weighs 49 kg. So this is her timeline. So 2018 is when we first see her, we get the imaging. We know that she has multiple large liver and kidney cysts causing mass effect, and she's classified as myoclinic imaging classification 1D. In 2019, she undergo interventional radiology procedures. She underwent two-stepped liver cyst sclerotherapy, and she underwent also two-stage sclerotherapy of her 3 largest kidney cysts. And you can see their sizes here. In 2020, she mentioned that her bloating discomfort symptoms has improved, and she started tolvaptan for her polycystic kidney disease. Here, hopefully, I've seen better images today. Mine are not the best, but hopefully we can see here. This is prior to her sclerotherapy of the liver cyst, and this is post. So we think, and there is some artifact, but this cyst that was targeted here, and you can see some degree of decompression of the liver cyst, and repeat MRI that show that there was successful decompression. Again, I have her timeline from 2022 to 2024. So in 2022, mass effect symptoms occurs once again. She undergo another left sclerotherapy of 4 cysts at this time, ranging in size from 6 to 5 centimeters. In 2023, immediately post-procedures, symptoms improve. However, later on, her symptoms reoccur. in early 2024, she undergo 2 more intervention for mass effect symptoms. So a few months ago, late 2024, she's seen again in clinic. She mentioned that there are improvement of her mass symptoms after her sclerotherapy. However, she still complains of ongoing mass effect. She's eating more frequent meals, smaller portions, and she's having difficulties in exercising. So this is my question, and I'm just gonna ask you to look at the answers. I don't want you to answer this right now. We're gonna have a look at one more image, and then we're gonna ask the question again. So these are the things that we thought over in clinic. What else would we do in her case? And on the next slide, I have 2 videos showing her latest MRI scan. I have a few still photos on the next slide. And now if we can go and think about what we'd like to do next in her case. I guess we only have one person who may have answered, or a few, but they're all choosing the same answer.
There are 5 responders.
Okay. Just going over them. So we thought of doing conservative measures where, as based on what we heard today and from Dr. Torres, another thing would be interesting in her case is, do we want to do somatostatin analog therapy in her case? That's something we could do. We know she's roughly around the age of 50, so hopefully soon she's going to go into menopause. Her liver is not going to increase in size as it has over the past few years. Cyst deroofing may work, may not. Additional sclerotherapy, that's something we're thinking of doing for her mass effect symptoms. Nephrectomy, I would say in her case, given that she doesn't happen to have any history of hemorrhage, kidney stones, her kidney function is okay, is not something that we would like to do for her at this time. We actually thought of repeating imaging one more time and then hopefully referring her for hepatectomy.
Yeah, so thanks very much. These are the kind of challenging cases, and I think everyone will have a component of these. I think one of the challenges to me in this type pattern of disease is that, and I think you see this, the benefit of sclerotherapy, and I think what Iran showed, and I don't know if Iran's still around the corner, there he is that probably if you've got a limited number of very large cysts, that sclerotherapy can be very effective. But when this patient has kind of innumerable cysts that are in the kind of 2 to 3 centimeter range, so you need to get a really and the benefit that she gets, symptomatic benefit, seems to be about a year, right? She gets about a year, and that's probably between interventions. So her symptomatic benefit is relatively short. In order to assess for hepatectomy, though, it looked like there was some preserved liver parenchyma on the left-hand side of the liver, but as Dr. Torres and I have shown, you need to really be very careful in assessing the blood vessels going into that component of the preserved liver, and particularly the blood vessels coming out of that portion of the liver. So again, I think that in this kind of a patient, and again, to see that, and I think what Dr. Torres says, that many patients will, their liver disease will slow down after menopause. The age at which people go through menopause is very variable, but some women will not, particularly if it's very large. So, I think this is the story that I keep hearing over and over again, and particularly in patients not treated at Mayo, we saw this, was that, you're waiting for something to happen. And so they're waiting to go through, they're almost hoping for menopause. And then when menopause hits, nothing changes. They still have that size of liver. So I think this is the kind of person that, again, would want to assess the vasculature, but is somebody that could do, and you could see there that, you can get a 60%, reduction in probably the amount of liver that she has. And that's durable for many years. So.
Yeah, so I mean, I agree completely with what Dr. Cleary said. I think the optimal patients for us are the ones that have, large cysts that we can go in and target and sclerose. I mean, looking at our MRI, there's probably room to be more aggressive with sclerotherapy if she wanted to avoid surgery. For a long time, we were limited by how much sclerosant we could inject, so we could only do 1 or 2 cysts. As we've increased the dose over time, we can do more cysts, but I mean, obviously you can't target every cyst here. So, she does have some large ones that could still be targeted if you wanted to temporize things a little bit.
I think one of the challenges we had over the years is that we don't have a dedicated hepatobiliary surgeon who is interested to do partial hepatectomy, and we have some kind of ad hoc kind of experience. And sometimes some surgeon may want to give it a try, and then usually these are oncological surgeons, and then if the result didn't seem optimal, they just throw out their hands and they just say never come back. So I think it's like anything, experience is accumulated, and expertise is also not a one-day kind of event. It takes a long time, and I think so. We're very fortunate to have you, and certainly, hopefully, we will have some patient that we won't have to wait so long, like to look like this. And that we could refer to you at a more optimal timing, maybe when the cystic disease is maybe in the B category, like that you think would be easier, like to manage than the difficult, more like C, like in this case. And so I think one thing I learned today is that at the Mayo Clinic, which is the world premier place for management of cystic disease, is a use of combinations of means to manage the mass effect symptoms. And so right now we have limited means, which is the sclerotherapy. We also use somatostatin. And I think if we have the surgery also as an option, I think that may provide a more optimal type of management. And also I want to hear from Dr. Torres.
Well, I think one of the problems with this case is these cases are very complex, and it's very difficult to give an opinion just based on the brief presentation. I think, from a surgical standpoint, of course, knowing the vasculature is essential, but many other things are also very important. I think that would be a case that knowing sequentially what has happened with the liver volume over time with the sclerotherapies, how effective the sclerotherapies have been, and be able to project what further sclerotherapy could do for the patient. I think knowing what the kidney function is right now, I don't think I have seen that. If a patient that is close to kidney failure, maybe depending on the surgical opinion of how safe the resection will be in that particular case, because there is some risk always with this type of surgery, and the only one who can give an evaluation of that is the surgeon. So knowing that, because the other possibility, if the patient has relatively advanced kidney failure, is to think about a combined kidney liver transplant. Because if that patient had very mild polycystic kidney disease, or was a case of isolated ADPLD, I would think liver resection would be the way to go if it's feasible. But if this patient is going to need a kidney transplant in a few years from now, then maybe thinking about the combined kidney liver transplant is the way to go, and then compromise with the sclerotherapies and some octreotide if necessary to wait for that time. And I don't know what the situation is. If the kidney function is normal, then I think that gives no, she has a lot of time ahead of her, and going ahead with the liver resection if it's safe, I think that would be reasonable, very reasonable to do.
Yeah, I think that's an excellent point, and I think Dr. Pei and I have had at least 1 or 2 patients where we've had this very discussion. Not only is the surgery a stress on the kidneys, but there are a lot of fluid shifts afterwards as the body is trying to reabsorb some of the fluid made by the residual cyst walls. And so we leave drains that have to drain out the fluid. Patients can get ascites, and you need to be able to, I always tell the patients, we're trying to shift that fluid from their abdomen out to their urine. And so you need good functioning kidneys. And so I think in the patients who have a combined liver and kidney disease, but also have progressive kidney dysfunction, surgery is not a challenge. So we've had these discussions of trying to time the particular patients who are going for kidney transplant, trying to time a surgery with a kidney transplant or even combined liver kidney. In Canada, the liver kidney transplant process is a little bit more complicated. It can result in longer waits, but it is something that is a good option, particularly again to get the exception points or the equivalent Canadian equivalent of exception points. It's hard to get it without synthetic dysfunction within the liver, but these are all very good options. And I think Dr. Torres brings up an excellent point, because when our residents and fellows see these patients, my first question is what the creatinine and the GFR is, because doing these type of operations in patients who are on the edge in terms of their kidney function is not a good option for the patient.
Yeah, I just have a quick question, I guess maybe for the radiologist, which is I was looking at those images and I couldn't tell where the liver and the kidney ended. Like they looked all together. So I was just wondering how the kidney volume was calculated, because I couldn't differentiate. So just wondering.
It was calculated using Tim's automated segmentation plus the radiologist's confirmation, understanding that in this kind of cases, the right kidney and the liver can be quite challenging in separating like where the planes are.
Yeah, because the liver was even all over on the left. I could not see any difference. So I was just curious.
It gets really challenging, but usually there's some parenchymal differences. Oh, sorry. It obviously becomes very challenging, but oftentimes there's some parenchymal intensity differences that can help drive really the differentiation between the polycystic liver and the polycystic kidneys, but it is a big challenge for sure. And we do see people often disagreeing on whether a cyst is attributable to the liver or the kidney, but that's a great question.
There's not much experience with embolization in North America, whereas in Japan it's reported as a highly successful procedure. Do you have any further insights into that, York?
We actually had tried that in several earlier patients before the sclerotherapy, and on paper, I mean, we read quite a bit, and it sounded like a good idea, but it seems to be not very effective. And perhaps one of the problems is maybe this patient, they may have bilateral circulation that you can't really completely choke off the main blood supply. And I wonder if Dr. Torres also want to comment.
Well, I think in terms of the embolization, now they have experience in Japan, a little bit in Korea, and in France, they have some good reports from France also. But if you look at the papers, the average reduction in volume that they get is about 16%. The reduction that you get with the liver resection usually is around, the mean is around 60%. So it's a much more effective procedure. And they say there are no complications, but all the patients that have embolization have post-embolization syndrome, which is a complication. And so it depends on where you practice. I think we have we have embolized one patient that I'm aware of at Mayo, and it did not, well, she did fine, but spent like 3 or 4 years in the hospital controlling the pain with IV medication, and I don't think the outcome was so brilliant in terms of the reduction of volume. So
my question leads on from that a little bit. In the case presented, the size difference between kidneys and liver was extreme, but it usually isn't quite as extreme. In a patient who had big kidneys, big liver, and symptoms, is there a confident way to say, well, I can be confident these symptoms are coming from the liver versus the kidney? I'd hate to take the wrong organ out. You know what I mean?
Yeah, I think your point is well taken because mass effect is whatever in your tummy that sets up. So, I mean, I know that literature, depending on your, like where the results are reported, whether it's by nephrologists or hepatologists, they all seem to have some bias in terms of either reporting total kidney volume or liver volume and correlate with some symptom. It seems to make more sense that we should consider combined kidney liver volume with like patient-reported outcome measure to see whether they would provide a better way of correlating to the symptoms. I think this is one of the challenges. You can measure volume, but then you don't have the patient-reported outcome on whether they have symptoms and what kind of symptoms. And so I think that I know that there was one paper that kind of addressed that, but the patient-reported outcome measure was very limited. And so I think we have some data which is emerging. I don't actually have the final conclusion at this time of looking at total kidney volume, liver volume individually, as well as combined kidney liver volume, how they correlate with the patient-reported outcome measure for mass effect.
Yeah, I think, as you mentioned, it can be very difficult to know what's the most contributing cysts. I think when we come to do sclerotherapy, a lot of times we try and ask the patient, like, what's the most uncomfortable? And a lot of patients will tell me, it's, right underneath my sternum, or I have one spot here under my rib cage that really bothers me. And then we try and see if we can find something big around that area to target. So occasionally, but obviously if you have a liver just full of small cysts, it's not very helpful, but occasionally patients can point you to whatever bothers them the most.
And just leading on, pardon my ignorance, is the skill for a radiologist in doing sclerotherapy a common or a specialized skill? We don't do it in our center. I'm just wondering if it's because nobody's ever asked them.
The technique itself is not particularly difficult. I mean, it's just like draining any other collection. There's some fine points about how much to distend and how to mix the foam, and whether you go through parenchyma or don't go through parenchyma. But apart from that, any interventional radiologist who drains collections anywhere in the abdomen under ultrasound should be able to pick this up.
I also like to add to your question. I think having a dedicated radiologist is important because we all make mistakes, and it's good to learn from mistakes. And I think having done many and then learn from the mistakes, you become better than if you just do it ad hoc, and anyone can do it. But the question is, can you do it well consistently? So that would be my point, because I think this is my observation, like from our institution, that we have like obviously people like Dr. Slomovich, who's very dedicated, and another kidney person doing kidney sclerosis, versus liver, in which is being done by a kind of a bigger pool of radiologists with varying results, and sometimes more complication that I would like to see as a referring doctor. Yeah.
I absolutely agree with this. procedure, but I think having someone who's dedicated to that is going to do it better than someone that does it casually and among many other different procedures. But
No, I agree. I mean, just like any other technique, the more you do, the better you get at it. But complexity-wise, it's not too bad. So if you have an interventional radiologist at your site that you think might be interested, I've had patients that reached out from other centers who plan to, come to Toronto to have sclerotherapy, and then I just had some conversations with their local interventional radiologists and kind of sort of guided them through some of the finer points, and they've started doing them locally. So
I have a question for the group now, because we have a potential decision here, whether you want to continue and finish early, or versus you want to take a coffee break and come back. We still have about 4 more cases. I think these are very interesting cases that we should take time to discuss. Do you feel you need to have caffeine injection at this time, or whether you want to go on? How about go on? Can you give me a show of hand? Okay. So why don't we just keep going? We'll skip the coffee break and yeah, you can go and get some coffee and come back. And so I'll ask Marisha to present. So we have several liver-related cases that illustrate different aspects of challenges. So I think that Marisha, you want to continue?
Okay, good afternoon to everyone. I will present us the case number 2. It's about a 57-year-old woman with ADPKD and liver involvement. She has a PKD2 mutation, Mayo Clinic imaging class 1B, and a positive family history. She also has high blood pressure. Here we can see the image on MRI. As we can see, there's an enlarged liver. There's an enlarged liver with multiple cysts. That gives a total liver volume of 8 liters, more or less, and a typical image of polycystic kidney disease. So these women came to the clinic, and she said that there was a significant mass effect with abdominal discomfort, abdominal distension, and bloating. So at that time that she was living in Ottawa, she had like normal kidney function and normal liver function. So she underwent a left hepatectomy in 2007 in Ottawa, with partial improvement of her symptoms. But 4 years after that, she has to underwent a laparoscopic deroofing because she was continuing to experience the mass effect symptoms. And after that, she didn't have any improvement. So she becomes, she had to take a lot of painkillers, including narcotics, high doses. So the question here is, what should we do next with this patient? And the options are A, conservative management, B, somatostatin treatment, C, sclerotherapy, D, transarterial embolization, E, hepatectomy, or F, liver transplant.
you said that patient had a left hepatectomy?
Yep.
But this is the level up of the liver, isn't it?
No, this image is after the...
That's after that?
Yeah, because that was in Ottawa, and we don't have the images of that.
Okay, so you don't have a scan before the hepatectomy?
No.
Okay.
Okay, so there's only one response, and everyone says somatotherapy treatment here. Okay. So I'm gonna take.
Re-
You have 2011 as the last date, and then you talk about pain management with narcotics. So are we in 2024 or are we
Oh,
in?
no. We are in after 2011, because I'm going to talk about her current status after that.
Okay, but 13 years of severe pain?
No.
No. Okay.
The question is, what will we do after 2011? At that moment.
At that, but she's no longer on narcotics.
No, at that moment she was on narcotics. So the question is, what would we do at that specific moment?
Yeah. I mean, I think that's a significant problem for whatever you do. But
She was, at that moment, is she 75 years old?
No, she was 60 years old.
60 years, so 75 now. I think
No,
2011
No,
was.
I started with 57. That was her age at the beginning.
Okay.
And that was when we saw her. But in 2024 is 60. I don't remember that. Can we pass to the next? Her current age is 62. No, I'm sorry, the 57 is wrong. That was when we saw her at the clinic in Toronto. So, well, the idea of this patient after her presentation in 2011, she was considered for a liver transplant, but at that moment, that was considered premature. So they sent her to the pain clinic. So they adjusted the analgesia with a good improvement of her symptoms. And she also underwent a foam sclerotherapy in 2021, targeting a dominant right hepatic lobe cyst that was around 6.6 centimeters. And after the sclerotherapy, it was just 5 centimeters. But after that, the patient told us that the mass effect symptoms were tolerable. And this one is the latest labs of her and the latest image. That image is from last year. And the total liver volume is almost the same as the first one that we have. That was around 8 liters. So in this case, what would you do next after the last slide that I showed?
I don't, if she already had a left hepatectomy and that's all the right lobe of the liver, kind of a change in position. It's kind of strange the way it looks, but I think another resection would be very difficult to contemplate. And if she is 62 years old only, I think in that patient I would go for a liver transplant.
Well, in her, can we show the? So yeah, everyone votes for somatotherapy. Can we go to the other one? Well, in this case, what we decide with the patient is to maintain the conservative management because she's 62 years old and her symptoms are tolerable. So and after the last sclerotherapy, there wasn't like a significant difference between the cyst that was targeted, so we decided to maintain the conservative management. So the next question is the question that what would you do if the patient becomes symptomatic with severe abdominal pain? In this case, the first option is intensified pain management. The second is somatotherapy treatment. The third one is sclerotherapy, hepatectomy, or liver transplant. This is in the case the patient comes to the clinic again and says that she has severe symptoms. Okay, so here we have two responses, says liver transplant. Well, in this case, of course, if the patient is again symptomatic, we should try to do, well, Dr. Cleary is not here. So as Dr. Torres said before, doing a second hepatotomy will be a little bit risky. So probably a liver transplant could be an option.
But yeah, one problem I think with this case and these cases in general, I think we need more information to make a reasonable decision of what to do. And because if this patient was severely symptomatic and I just don't have a good idea of the clinical course and is progressing, and I don't think, I think eventually she is going to need a liver transplant. So postponing that, I don't think it's a good idea. But again, I think we are missing information on this patient. I would like to, I don't have a comfortable feeling that I know the patient. Yeah. And I think I would like to see sequential images and more information about the patient in general to really feel comfortable about recommending one thing or the other. It's
Vincente, I think that the first, the quiz before that is real life for this patient. This is a hypothetical question.
I understand that, but even before, I didn't have enough understanding of the patient to recommend anything.
Yeah.
I think the only image we have seen is an image after a surgery and what has happened after the surgery that she had many years ago. And I think we need to have some information about that before deciding what to do.
So this is a patient who had multiple types of intervention at different institutions. So we don't have access to the information other than the history. And then we saw her recently, and I think the only option we could offer her and was some form of sclerotherapy, which didn't seem to be successful because 6.5 to 5 centimeter targeting change of the cyst, I wouldn't call it a success. But then she claimed that her symptom is tolerable, probably because of better pain control, and she can live with that. So to our mind, given her age, we thought we would probably offer conservative therapy at this point until she gets into more trouble, like if in the future. But so in contrast to the first case, which is a little bit different, her age, she's much older. So we're hoping that maybe her symptom will be tolerable and then manageable just with conservative therapy.
So continue with case number 3. This is a 31-year-old woman. When we saw her in the past, she has ADPKD with liver involvement, PKD1 protein secreting mutation class, Mayo Clinic class 1D, and she also has a positive family history. She also has high blood pressure, endometriosis that require hormonal treatment in the past, anxiety. She's a school teacher. And here we can see the image of her in 2015 when she was 31 years old. The total kidney volume was around 1.6 liters and the total liver volume was around 9 liters. As you can see the image, the liver is really enlarged, occupying almost all the abdominal cavity. So the first question is, which factor is associated with a higher risk of aggressive liver cyst growth? A, male sex, B, proteinuria, C, hormonal therapy, D, postmenopause, or E, all of the above. Okay, so this was kind of a quick answer. as we know, as Dr. Torres explained earlier, hormonal therapy is a risk factor for liver cyst growth. So we have these patients, 31 years old in 2013. At the beginning, she came to the clinic with significant mass effect symptoms. At that time, she has normal kidney and liver function. So in December of 2013, she underwent an elective right hepatic artery embolization. After that, she didn't have a big improvement of her symptoms. So the question is, what to do next after the elective right hepatic artery embolization in 2013? So the options are A, somatostatin treatment, B, sclerotherapy, C, nephrectomy, D, hepatectomy, or E, liver transplant. There is not only one answer because we're talking about a patient with significant mass effect symptoms in 2013. So what at that time the clinic did was to refer the patient to the liver transplant clinic. At that moment, the patient wasn't a candidate for transplantation at this point. She also was referred for a surgical team, and also the surgical team denied a liver reduction surgery at the moment in 2015. Because of that, the patient was with significant mass effect symptoms. She was only 32 years old. She contacted the Mayo Clinic to ask about the possibility of liver reduction surgery. And they validated the case, and they said that she was a candidate for extended right ME hepatectomy at the moment. But she did not continue with this because of financial reasons. So she was resent for a surgical team here at UHN. So after that, what would you do next? Would you do offer the patient somatostatin treatment, B, sclerotherapy, C, nephrectomy, D, hepatectomy, or E, a liver transplant? Well, here, okay, we have more responses here. The majority.
You can do somatostatin,
yeah,
and it's not. They are not.
Yeah, as I said, there's not like just one correct answer in the case. So she was then, after referring her again to the surgical team at UHN, she was accepted as for a cadaveric liver transplant. And she was lucky because she was able to find a live donor and receive a live liver donor transplant in 2016 in February. And a few months later, she experienced a significant improvement of her symptoms. Here's her current status. As you can see, she's 43 years old right now. She's doing well with no abdominal symptoms. Actually, she got pregnant this year. And her, as you can see, the image after the transplant, the liver volume is just 1.6 liters. The kidney volume is around 1.8, and she's doing well. So the take-home messages from the KDIGO guidelines. ADPK patients with polycystic liver disease should receive treatment if they experience cyst-related symptoms or complications that negatively impact their quality of life. and the determination of treatment type should be based on symptoms, liver cyst size and distribution pattern, the total liver volume, and the treatment availability in every center, of course.
I just want to add a couple of comments because the case presentation appear really simplistic because of the structure of the format. So there's a lot of information missing, and it looks like it's so easy decision, but it actually was a very difficult process, as you can imagine. This is a young teacher who are really look like she's 9 months pregnant permanently and had suffered a lot in terms of quality of life. The problem is she get bounced back and forth between the transplant general surgical team and we were not able to offer her sclerotherapy because most of the cysts were small and such diffuse disease. So eventually she get transplanted to the cadaveric transplant program, but the problem is she's on the bottom of the list. She will probably never get transplanted because she does not have hepatocellular dysfunction. Even though with the newer classification, she may be getting some extra points, but she will get bounced every time when the liver is available.
In that case, I think being on somatostatin analog, it may extend her, kind of breach her toward the transplant. At the same time, her kidneys don't look very good. So has a rapidly progressive disease. And although her GFR is 58, probably 2 or 3 years will be quite lower. And then maybe she can be pushed up because of the need for a combined kidney liver transplant at that time. But again, these are cases that are very difficult to have a brief reaction because, for example, in this case, I'm surprised that Mayo offered her a right hepatectomy because the left lobe looked terrible, but we don't see all the images. Mm-hmm. So maybe as you go deeper into the images, you can have a good part of a very good left lobe. But the images that I show here, I don't think she would be a candidate for liver resection. Yeah. So that's the issue, kind of.
Yeah. So I think what is really interesting is she reached out, she kind of thought out of the box, and she had a social media platform, and she was appealing for a donor, and then she was very lucky to get an altruistic donor who gave her like part of the liver. So it really changed her life dramatically. So this is really a very...
It's truly altruistic.
Yeah. Okay, so continue on.
Good afternoon. I'm going to present the fourth case. And this is a 32-year-old woman with ADPKD due to a PKD2 mutation and a positive family history on her maternal branch. She also had asthma, intrauterine fibroid, and a polyp. She had a normal kidney function, and we saw her for the first time with an ultrasound that just reported bilateral renal cyst and some liver cyst, the usual. So in her first visit, she expressed her conception desires, and she has a female partner. Our first question is, how would you approach the conversation about family planning with a patient with ADPKD? A, advise focusing on her disease management before making any family planning decisions. B, order an MRI for risk assessment before having that discussion. C, discuss reproductive options, including preimplantational genetic testing. D, refer her to a genetic counselor, and she has that conversation with the genetic counselor. E, B, and C are correct. So we have B and C. We have referred her to a genetic counselor. And I would like to raise the discussion with the panelists. What would you do? How do you approach that conversation with our patients? Do you think that we as a nephrologist are doing like the right job explaining the patients or having that conversation about family planning with our patients? Maybe Dr. Perrone or Dr. Torres, if you want to comment on that.
Well, I think certainly we should be able to provide an initial discussion with the patient. And I think there's no problem with a referral to a genetic counselor, but I think we should be able to provide the initial discussion and certainly she needs to have an MRI if she hasn't had one before. And I think we can discuss the reproductive options with the patient. I think about advising, I think for some of the options that she would have, referral to reproductive medicine would be, which may include a genetic counselor or a genetic counselor at that would be reasonable. But I think initially, I think we should take care of that.
Yes. So. Okay, thank you. So we did an MRI, and this is the report of her MRI. We can see that she has mild polycystic kidney disease and mild polycystic liver disease. Her HTTKV was 283, and her Mayo Clinic classification was 1B. Her TLB was 1,576 milliliters. So having this in mind, what would you do next? A, advise moving forward with her pregnancy. B, refer her to a genetic...
Just one question. You called her Mayo 1B. Does she meet the criteria of class 1? And the images you showed us are not, of the kidneys are not, there's not diffuse cystic enlargement. So is she a class 2?
Yeah, that's correct. That you're right, because she has this large cyst that I think it was accounting for her kidney volume. That kidney volume, in fact, in the evolution, she underwent sclerotherapy, and her kidney volume significantly decreased. So it was probably related to that. You're correct. She has just one large cyst. So the question is, what would you do next? A, advise moving forward with pregnancy. B, refer her to a genetic counselor. C, refer her to a fertility clinic. D, advise against pregnancy. Or E, B, and C are correct. Nine, I think.
Do you need referral to a genetic counselor to do the genetic testing?
Not us. It depends on the type of genetic testing. For example, if it's research genetic testing, we don't need to refer her to a genetic counselor. But if it's clinical genetic testing, we usually refer patients to genetic counselor, especially if they are going to start a reproductive or fertility process. Yeah, but it's important for us also to have this discussion, because many of the times, like in many clinics, they don't have the possibility of having this discussion with patients, or they don't have the possibility of refer them to genetic counselors. So that's why we wanted to know or to understand what would you do in these cases. Would any of you recommend against pregnancy in this case?
I think it's very important you don't tell patients what to do, right? You outline the potential risks, and then the patient makes their own decision. So you could tell her she has liver cyst disease, and if she ends up getting in vitro fertilization with all the hormone treatments, et cetera, that there might be worsening of her liver cyst disease. But her liver cyst disease is not terrible, but could be terrible in the future. And I think you really want to know her genetics because of, in terms of her kidney prognosis. And yes. Also, is this one of the minor ADPKD, minor PKD genes?
It's a PKD2 mutation.
It's known, okay.
Yeah. Yes.
In our center, I guess I have the luxury, I would do everything first of all, I would do the genetic testing for exactly the reasons you were describing. I work with a fabulous genetics counselor, and I would send her to that person for that, to slant that take on the whole picture. And I also have a colleague in Edmonton who specializes in high-risk pregnancy and pregnancy associated with renal disease, and I would refer her for preconception counseling with that individual as well. And these are all the kinds of information I think she needs to decide about pregnancy. But I agree, I wouldn't be the one to say, don't get pregnant.
Thank you.
I think in this case is a little bit unusual because we actually gave her all the options, including IVF and pre-implantation genetic testing, because that's how she would be able to conceive. I think that depending on her response, then we may move further if she wants to go through IVF and pre-implantation testing. Then we have more experienced kind of genetic counseling, not the general one. These are people who are really focusing on pre-implantation genetic counseling and work closely with fertility clinic, and which would be the step that she would take if she chooses to. Yeah.
Because how is she going to get pregnant?
She would get some kind of anonymous sperm donor.
So that would require, referral to reproductive medicine in our institution. So, and she already knows the type of mutation that is PKD2.
Yeah.
So from my standpoint, I would provide the counseling about what it means having a PKD2 mutation in terms of the kidneys and in terms of the liver. In terms of the kidneys, is pretty reassuring. In terms of the liver, not so much, because, but still she's 30 years old or
32. Yeah.
32. So still the liver has a possibility of growing. It doesn't looks mild at the present time, but it's difficult to predict what the effects of hormonal stimulation would be on a case like that. So, and I don't think that anyone in reproductive medicine would be able to give her a better opinion than we can give her in that regard. But there are a lot of other aspects that need to be dealt by reproductive medicine because we are not qualified. So certainly I would refer her to reproductive medicine, but I would give her my opinion about the prognosis that she has in terms of the kidney and the liver. What we can say, which is some of this is questionable.
I don't know if the uterine fibroid or the uterine polyp has any importance in her reproductive decision making. I don't know if there strikes me that they're not major issues. The other thing I would be curious to know what are her future plans in terms of getting pregnant? Because I think the general advice to people with chronic kidney disease is sooner is better than later, and whether there's social factors or some other reasons. But
yeah, that's a good point. You have a comment here?
It's interesting. I wondered if anybody's, or have you contemplated some of the ethical dilemmas here as well? I have a heterosexual couple going through a similar sort of thing where the mother is affected and the father isn't, and they're considering pre-implantation genetics and things like that. And it surprised me that, having developed the probe for polycystic kidney disease, they say if we're going to do pre-implantation genetics, let's expand the panel into a whole lot of other things that they just sort of came out of a hat with, just in case. And it brings up the ethics in a same-sex couple with an anonymous sperm donor. You can test for polycystic kidney disease, but what about the donor? You won't know anything about the genetics of the donor, and you might feel artificially reassured in pre-implantation genetics, only to find out that your sperm donor had something else.
That's an excellent point, and that's something that probably would be discussed in the referral to the reproductive medicine, because I'm sure they have this issue all the time.
The other problem is if you find something that may be potentially deleterious, does it necessarily mean that the patient will be predisposed to a specific disease? It probably may depend on the type of mutation, like high impact mutation, but even that is not absolute. And so I think there are a lot of ethical consideration because of this whole exon, whole genome type of sequencing, and finding a lot more than you actually want to know. And I think that should be one of the risks that had to be discussed as part of the testing. Yeah. Mm-hmm. So there's actually more to come.
Yeah.
So the patient was referred to a fertility clinic. They explained her all the process to her and her couple, and she decided to freeze her eggs for future pregnancy. So she was also explained that she will have to use hormonal treatment, folitropin alpha and metropins to stimulate the ovulation. So seeing this and her MRI, would you advise against hormonal treatment? A, yes, it's too risky and her liver disease can progress. B, no, she can proceed and we can follow her closely. Okay, so she can proceed and we can follow her closely. Very good. Everybody thinks that. So she decided to go on with the ovarian stimulation. After that, 2 years later, we did another MRI, and we can see that her total liver volume, it's similar, it's very similar, 1500 after ovarian ovulation. Then if we can see here that after 3 years, having 37 years old, we can see that we saw her for the first time here at 32 years old. Her total liver volume was 1,577. She underwent the ovarian stimulation. The total liver volume, 1,537. Then in 2023, this is her MRI in 2023, 1,579. And she decided to undergo IVF herself. So she receives 3 IVF cycles in 2024. And after that, we have this MRI after the 3 IVF cycles. So her total liver volume was 1,877 milliliters. So yeah, these were the previous ones. And this is her last total liver volume, meaning that her liver volume increased 300 milliliter after the 3 cycles of IVF.
One thing is that I think these liver volumes are misleading. If you had cis volumes, the percent increase probably would be much higher. That's what I mentioned before in my talk, that the cis volume is more sensitive than the liver volume. In the kidneys, you get basically the same message, but in the liver, the percent increase is much larger with the cis volume. So I think with this increase in cis volume, that probably should have raised maybe some concern.
Okay. Anyone has another comment? Yeah, so we actually saw this increase in cyst volume. Unfortunately, we don't have like the way of measure the cyst burden in the liver. So we just have the liver volume measurement. So after seeing this, at this point, what would you advise to her? A, continue with IVF cycles since the liver growth is not significant. B, continue IVF cycles since she is asymptomatic. By the way, she was asymptomatic. C, advise against more IVF cycles due to her risk of progression. D, advise patient to consider other options of surrogate pregnancy. E, both C and D. Unsuccessful. Oh, I don't know exactly the reason, but because we don't. Yeah. Yeah, that's true. Unfortunately, we don't have the reports. She just came to the clinic and she said that we're unsuccessful. Yeah. So we have both C and D, meaning advice against more IVF and advise patient to consider other options of surrogate pregnancy. So finally, the patient decided to stop the IVF cycles and have her female partner carry the pregnancy. I think that it's like the discussion we had here is very important because, first of all, it's important for us as a nephrologist not only focus on the kidneys, because that's very frequently. We focus on the kidneys and sometimes forget the other side of the patient, her reproductive life and the other concerns that she may have. And what you mentioned before, it's very important too. And Dr. Perrone also mentioned it. We have to provide advice, give her all the information that we can give them. And at the end, they are the ones who will take the decision with the right information that we will give them. Case 5.
Done well.
Hello, everybody. So I'm going to present the last clinical case, and I'm sorry, but we are no longer going to talk about liver. So we are going to talk about a 23-year-old female. She's having a positive family history of ADPKD. She's having a personal history of hypertension, hypothyroidism, and Raynaud's phenomenon. She's a non-drinker, non-smoker, and her medication include amlodipine and levothyrox. The first time we assessed her, she was having a controlled blood pressure. Her creatinine was 68 micromole per liter, and her eGFR was 94 milliliter per minute. Her genetic testing was positive for protein truncating PKD1 variant, and her HTT-KV was 337 milliliter per meter, which put her at a Mayo Clinic imaging class 1B. So in front of this high-risk genotype but low-risk imaging assessments, we decided to conduct a conservative measure with the increase of our water intake to at least 3 liters per day and pursuing the control of our blood pressure. And during the follow-up, we noticed that she experienced a progressive decline in her kidney function with an eGFR around 30 milliliter per minute in 2023, with a low-grade proteinuria and a persistent hematuria. So the question is here, what is the next step? Are you doing a clinical, laboratory, and imaging reassessment? No change in the management, which includes both medication and investigation. Are you initiating ACE inhibitor? Are you initiating SGLT2 inhibitor? Or are you initiating tolvaptan?
So
it was almost 10 years. For just in order to summarize, I'm not going through all the steps that were in between, but through a follow-up. Oops.
So just a quick question.
Yes?
You said she was Mayo 1B.
Yes, exactly.
These cutoffs are arbitrary. That is, they're not determined by God. So how close was she to the border of 1C?
I am not exactly sure of that. I'm sorry. I'm not able to answer your question.
Certainly in the new KDIGO recommendation, it's recommended that you, for people who are on the border, you look at other risk factors. And so she has the risk factor of the truncating mutation.
Exactly.
I mean, it's easy to say now that you've seen her downhill course, Has she had other imaging in the
Yes.
last 10 or 12 years?
Yes, of course. I am not presenting them all, but she had several imaging reassessments, and I'm going to show you the latest one that was performed in 2023 to be able to answer fully to your question.
I think also that the appearance of the kidneys on this MRI with has really no areas of healthy parenchyma. Is all full of microcysts. They are small cysts. And I think with one of the advanced imaging parameters that Tim Klein is developing, that would have indicated that she is at a higher risk than indicated by class 1B because of the total kidney volume. So
she's one of the patients that we have seen with a high-risk genotype, PKD1 protein truncating mutation. And the imaging is also high risk in the sense of numerous number of cysts, except that they are small. So in contrast, like for her age, many patients at that age would also have ping pong paw size, orange size cysts. So that may be why she's classified as 1B. So we have seen a bunch of patients like that. That phenotypically they seems to have much lower total liver volume, and typically they do very well. So this is a discordance between genotype and phenotype.
And I think that's why it's important for the nephrologist to look at the MRI, because that's a situation like this one that you look at it and if I didn't know that the liver volume was corresponding to a class, to a B, 1B class, I would have guessed that it would have been worse just from looking at the MRI. So, yeah.
Again, how close to the border of 1B and 1C?
She had multiple MRI probably every 2 to 3 years. This is not given here. And it's always 1B.
But in the middle of 1B or on the edge?
That I don't know. Yeah.
That distinction.
Yeah.
We have another comment.
I'd just be slightly controversial and address the elephant in the room. We know that polycystic kidney disease is almost always progressive. And we talk about these classifications, A, B, C, and D, primarily based on the studies that started with total kidney volumes of 750. If our available agent was 30 cents instead of $30,000, wouldn't we start everybody on it?
If it was like holy water without side effects, yes, but unfortunately it does have side effects.
So I also like to just comment that even if she's 1C, her rate of decline is just too fast. I think that's the surprise here. Like in retrospect, if you look at that, like it just creep up on us. Like again, rare mirrors. It's like you have the crystal ball type of thing. But as it evolved, like every year we see her kidney function is dropping, and then when you look back, it become more confusing to us, like what to explain, and then we become very concerned that there's something else going on.
Does she have any other? Has she had just a specific genetic testing for PKD1 mutation, or has she had a whole panel looking for those cystic genes? Because in patients that have ARPKD, for example, they may have a small cyst, but they develop kind of fibrotic phenotype that the kidneys become scarred. And this patient, the fact that her kidney function is going down so fast, but does not have exploding cysts, suggests that there is another process going on. Exactly. And maybe is a more complex genetic disease than just the PKD1 truncating mutation.
Exactly, Dr. Torres. In fact, the genetic testing that she had initially was focused on PKD1, PKD2 variants. And to just explain you a little bit more about the 10-year that you saw and for which you have the feelings that we did nothing. But she had several reassessments of her imaging, and her MRIs was always showing a persistent HTTKV, and she was always a grade 1B. And tolvaptan had been offered to this patient several times, but initially she was having a project of pregnancy. And after the project of pregnancy, she was not having any drug coverage. So tolvaptan has not been initiated for her for all these reasons. So if we are just keep going on this case, repeat imaging in 2023, still stable, no new clinical findings. Blood pressure, yes, blood pressure always under control. And we perform an immunological investigation, which was positive ANA, a slight consumption of a C3 complement fraction, and a diffuse polyclonal increase in the gamma globulin region. So the next question is, what are you doing? No change in the management? Are you offering a kidney biopsy, initiating ACE inhibitor, SGLT2 inhibitor, or tolvaptan? It was still below 0.5 gram per day. Yes, slightly below 0.5. And she was having a persistent hematuria.
Does she have anything that go along with the polyclonal hyperglobulinemia, something like could suggest Sjogren's syndrome or some other acquired kidney disease that could explain the polyclonal hyperglobulinemia and maybe some interstitial renal disease?
Her clinic was pretty poor, actually, and she was only having the Raynaud's phenomenon, which could maybe make her think about an immunological and inflammation process, but that was the only thing.
She had testing for Sjogren's?
I don't think that she had saliva biopsy, for example, but she was not having syndrome sec. I don't know how to say it in English. No dryness of her mucosis.
In her initial history, was there a mention of Raynaud's?
Yes, she's having a Raynaud's phenomenon.
Okay. So, I mean, the positive ANA in the low complement suggests there's something going on there that is different than PKD.
So this is why we performed the kidney biopsy. The light microscopy was showing 13 glomeruli that were shrunken, 8 that were sclerosed. There was a moderate to severe interstitial fibrosis and tubular atrophy, and 2 fragments shows a collection of macrophages. The immunofluorescence was negative for IgG, IgM, IgA, C3, C1q, kappa, and lambda. And the electron microscopy was showing a glomerular basement membrane diffusely thin with a moderate effacement of the podocyte food process. So because of these electron microscopy findings, we performed a second genetic testing, which shows a COL4A4 variant, which is a novel variant, but predicted to be pathogenic by the 8 out of 8 algorithm. So as a conclusion, this patient has a thin basement membrane and heterozygous COL4A4 variant predicted to be pathogenic. The presence of the COL4A4 variant may have modified the severity of her ADPKD, and at this time there is no definitive evidence of lupus.
So she has 3 diseases.
Probably 3, yes. Do you know that? Was it interventional? Oh, that was an interventional radiologist.
They have a protocol for patients with ADPKD, so they are like very good, and they try to find places or spot without any cyst. So they have this protocol, and it's been good for our patients so far.
So that's a good example when the images and the kidney function do not correspond. There's something else going on.
Exactly, yeah. And that's the take-home message probably of this case. If you see that there is a mismatch between the imaging, the genetic, and the evolution of the kidney function, we have to think about other causes.
And I think this is one of the point that I kind of want to raise, because the European, they are more heavily rely on EGFR-based risk assessment, and sometimes it may not be so obvious to pick up a complication that may result in a more rapid decline of EGFR without imaging. Because like, I think in this case, it really illustrates that when you have what looks like a mild pattern of cystic disease burden and discordant EGFR that you cannot explain, we have to look harder. Obviously, if she had high-grade proteinuria, that by itself may be sufficient, but sometimes these cases may not be so obvious.
So a lot of the genetic testing that's being done in the States is basically a 392 gene panel by Natera. I don't know if they've penetrated across the border, but that would include a lot of the, the COL4A and these other related mutations. It's hard, in retrospect, what would you have done differently in the beginning? Because obviously you have a 12-year course of rapid deterioration, but was there any way in the beginning of knowing any of that?
So her genetics testing was done clinically when she first came to see us. So it was done by another facility, and they only test PKD1 and PKD2. So now in our center for probably 10 years now, we offer them a gene panel, which would include the COL4 gene. And so we see this kind of variant relatively frequently. I guess it's been estimated maybe 1% of the population may have thin basement membrane disease, which, depending on how you like to frame the terminology, it's really a carrier state of a recessive Alport syndrome. And they could have some phenotype, but generally do very well alone. But if you have a second disease, it may modify potentially and make the disease more complex to interpret.
I wasn't going to comment on that, but it sounds reasonable. Some of the patients with the COL4A mutations without PKD nonetheless present with kidney cysts, and we've seen a few of these patients referred as having polycystic kidney disease, and the genetic testing revealed no evidence of polycystic kidney disease, but just the collagen mutation. And the question is, why do they get cysts? And maybe that's acquired cystic disease.
Well, I think collagen in the basement membrane does have a lot to do with controlling. Well, the extracellular matrix has effects on cell proliferation, and I think there is something that has not been sufficiently investigated, but I think that there is a reason for the proliferation of these cells, and the cysts has to do with the regulation of the cell proliferation by extracellular matrix. We had a seminar about that at Mayo about this, but I don't remember exactly all the intricacies of this, but there was some very nice connections.
I think it's a very difficult interpretation, because the call for A3A4 variants also appear to be, there are reports that they are also enriched in people with IgA nephropathy, in FSGS. So in my mind, it's unclear to me, because maybe this is relatively common. And as kidney specialists and doing research, you may pick up more cases of this kind of variant by urinalysis, because they have hematuria. And then IgA nephropathy, you may pick them up as potential IgA nephropathy, because hematuria is one of the features and similarly for FSGS. And so this may be kind of guilt by association. That would be one possibility. And the other possibility is maybe they may predispose to cyst formation because of the collagen defect. And so it's unclear, like in my mind. Yeah.
Just going to say that I have a patient whose father has thin basement membrane. I mean, and they're fine. They're like in their 60s, just have a little bit of microscopic hematuria. The mother has PKD. It's a PKD2 change, and she's kind of mildly affected. The kid, he's a male. He has both, and he's much more severely affected with bigger kidneys than the mother. So I'm just assuming that's the reason.
Yeah, well, yeah, I'm of the opinion, but I cannot prove it, that actually the association of COLE4-3 and COLE4-4 and even COLE4-5 with cystogenesis, I think is real. I don't think it's just by chance, but yeah.
Again, I guess it's just anecdotal because.
Yeah. Yeah, Peter is, I think they are working on a manuscript, or maybe has already been submitted.
Any other questions from the audience for any of the panel experts? I think we have a lot of interesting discussions, and so I want to thank everyone for taking the time to come, and especially our expert panel who has been really giving us a very exciting and informative day of learning. And so I want to also thank the online audience, and we will have the lectures available and download eventually to YouTube so that it will be available. And all you need to search would be Toronto PKD Conference 2024. Hopefully give us a few weeks, they will be on the YouTube. Thank you very much, everybody, and have a nice day.